and welcome today to today's ORDI Info Series. It is my pleasure to introduce our esteemed speaker, Dr. Nikhil M Kumar, sir. He is a consultant in clinical hematology, hematology-oncology, and bone marrow transplantation at Rajagiri Hospital. Dr. Nikhil Kumar, sir, has completed his MBBS from St. John's Medical College, MD in internal medicine from Guwahati Medical College, and DM in clinical hematology from AIMS, New Delhi. His expertise and research interests include plasma cell disorder, bone marrow transplantation, and advanced cellular therapies such as CAR T cell therapy. He also has contributed to several landmark clinical trials and also presented extensive at both national and international conferences. We are truly honored to have him with us today and to share his knowledge and insights. Welcome, Dr. Nikhil, sir, and thank you for joining the ORDI Info Series. The stage is yours now. Thank you, sir.
Thank you, Mr. Nadim, for that kind introduction. I'll just share my screen.
Sure, sir.
Yeah. Perfect. So is my screen visible in presentation full screen mode?
Yes, sir.
Perfect. So good evening, one and all. At the outset, I would like to thank the Organization of Rare Diseases India for inviting me over for this very important talk on AL amyloidosis. I wouldn't call this a rare disease. I would say this is a common disease which is rarely diagnosed. And very often it hides in plain sight and it evades diagnosis not for weeks or months, but years altogether. And the sad truth is, by the time we diagnose the disease, very often patients have advanced stage disease with cardiac involvement, which makes the overall prognosis dismal. So, over the next 30 minutes or so, we definitely would be making an effort to simplify the diagnosis of this disease, which has a varied clinical presentation, and how can we go beyond the ordinary to see whether we can cure the disease with transplant and newer treatments available in this. So I thank the Organization of Rare Diseases for organizing this webinar and inviting me as a speaker. Over the next 30 minutes, we hope to cover amyloidosis under the following headings: a case-based discussion on diagnosis. What are the early signs to recognize the disease? Once we have a suspicion, and I think the most important thing as clinicians is to suspect this disease, how do we diagnose it? What are the first-line treatment options available? Can amyloidosis be cured? And what is the most cost-effective treatment that we can offer these patients in India? And if and when the disease relapses, what next? There was a very interesting study which was published a few years back in the British Journal of Hematology, which actually looked at the time from system onset to diagnosis of the disease. And it was seen that the average duration between the onset of symptoms to diagnosis was at least more than a year, and sometimes as long as 3 years. And 3 in 4 patients see 3 or more doctors before AL amyloidosis is diagnosed. Now, what does this tell us? This essentially tells us that the symptoms are very subtle and mimic many other diseases in its initial stages. And patients usually go to other doctors, including general practitioners, physicians, nephrologists, cardiologists, neurologists, and so on, before they reach a hematologist. So the sad truth is, this leads to an unacceptable delay of sometimes years between symptom onset and diagnosis. And this is a major reason why the outcomes associated with this disease are still dismal. It is not because we don't have effective treatments which can potentially cure the disease. It is because of the simple fact that the diagnosis gets delayed. Let's go through this case of a 58-year-old gentleman, a bank manager at my city, non-smoker, occasional alcoholic. So patient presented with symptoms of fatigue, which progressively worsened over 8 to 9 months. He was an avid athlete, used to play badminton daily. However, over the last 3 4 months, the patient is unable to carry out his day-to-day activities. He started developing swelling of legs, and many of his colleagues told it's probably because of age that you're getting swelling in your legs. And this was also worsening with time. Over the past 1.5 months, patients started developing breathing difficulty. Someone who used to play for half an hour, 1 hour, 2 hours was finding it difficult to even walk for 100 meters. He had significant weight loss of 5 to 6 kgs in last 6 months. And he also had other features like numbness in the legs and easy bruisability. So this was the timeline of events. We saw him at month 18, but throughout the course of his illness, he met a general practitioner who identified that patient as low hemoglobin, started him on iron supplementation. Week 3, patient had breathing difficulty, ended up with a cardiologist who diagnosed him with heart failure and started the heart failure medications. Month 10, patient visited a nephrologist for swelling in both lower limbs. Nephrologist did a urine test which showed significant protein loss in the urine, and a kidney biopsy showed nephrotic syndrome. And later on, when he developed tingling and numbness in his limbs, he visited a neurologist who diagnosed him with peripheral neuropathy. So this took away a good 1.5 years. So as you can see, the first symptom, by the time patient came to us, patient already had nephrotic syndrome, heart failure, peripheral neuropathy, and patient ended up with us after a year and a half when symptoms started. So this is the problem that we should address. The delay between symptom onset and treatment can be sometimes very long, and this leads to dismal outcomes. So connecting the dots, all of this could be initial symptoms of primary amyloidosis. Patient was finally diagnosed after 1.5 years with amyloidosis involving the heart, kidney, and nerves. But unfortunately, by the time we diagnosed him, his cardiac condition was very bad, and he was classified as Mayo stage 3B, which is basically advanced stage AL amyloidosis. So, what did each doctor miss? Unfortunately for us, including our own practice, we are often restricted by our conical view and we see only our particular system. So the cardiologist did diagnose the patient with heart failure and preserved ejection fraction. Patient had low voltage on ECG. This is seen in very, very few conditions, and this should have brought out a diagnosis of amyloidosis then and there. A nephrotic range proteinuria, but ultrasound showing normal size kidneys. Again, this is a subtle clue that this is probably something unrelated to a primary renal pathology, and this could be a systemic manifestations. Every neuropathy is not diabetes or B12 deficiency. So whenever patients have symmetric, painful bilateral peripheral neuropathy, we have to think beyond the usual. Patient also had characteristic features like redness and periorbital purpura, which is a very pathognomic feature of AL amyloidosis. And when we examined the patient closely, patient had mild macroglossia or tongue swelling. The periorbital purpura and macroglossia are pathognomic features of AL amyloidosis. And this disease comes with its own share of constitutional symptoms like weight loss, diarrhea, and early satiety. These are very, very classical clinical signs which we should never miss. The raccoon eyes, it is seen in only 10-15% of the patients. Macroglossia, which is seen in only 20%. But these are both clues of early amyloidosis, and these are pathognomic features. How do we identify the disease? So essentially, AL amyloidosis is a disease where plasma cells in the bone marrow make abnormal light chain. As we all know, the production of hemoglobin, platelets, WBC, our bone marrow is our body's factory, which makes blood cells. Plasma cell is a particular type of cell in the bone marrow, which in normal healthy individuals makes immunoglobulins, which are responsible for immunity. However, when there is an abnormal increase in the number or function of plasma cells, it starts making abnormal proteins like kappa or lambda. And amyloidosis is essentially a protein misfolding disease. Now, what does that mean? It basically means it is a disease where abnormal proteins are produced in large numbers and there is a problem in the protein folding. These proteins get deposited in the heart, kidney, nerves, and cause characteristic symptoms. So essentially, the problem starts with increase in plasma cells in the bone marrow, and this leads on to amyloid production, which gets deposited all over the body and causes protein. This pathogenesis is important to understand because when we treat the disease, it is not the heart or kidney or lung that we target, it is the plasma cell clone that has to be targeted. Is it a rare disease? May not be in the Indian setting. The incidence is around 12 per million, but it is highly unrecognized because patients very often are underdiagnosed. The median age of presentation in Western countries is 65 years, but in Indians, we like any other disease, we see this disease sometimes earlier on in 40 to 50-year-old also. The unfortunate part is 60% of the patients, by the time they present to a hematologist, have cardiac involvement. And this is one of the factors that accounts for poor prognosis in this disease. 70% of the patients have proteinuria, which presents with symptoms like frothing in the urine and swelling of legs. All over the world and even in India, this disease is massively underdiagnosed. Indian patients tend to be younger at presentation and have more aggressive disease or are at a more advanced stage at the time of presentation. It is important to understand that primary amyloidosis or AL amyloidosis is not the only type, and there are other types of amyloidosis like ATTR, which can also mimic this disease in terms of cardiac involvement. And this has also been increasingly recognized in the Indian population. Which organs does amyloid affect? 60 to 75% of the patients' heart is affected at the time of diagnosis. It presents with heart failure with preserved ejection fraction. One clue to diagnosis can be a low voltage ECG, and echo shows thick walls. The other organs which are commonly affected are kidney in the form of proteinuria. Patients often present with frothing in the urine, swelling of both legs, swelling in the face. Neuropathic symptoms are seen in around 20% of the patients with peripheral neuropathy, autonomic dysfunction. Very often, patients with amyloidosis have reduced appetite, sometimes vomiting, loose stools, altered bowel habits. And this is because of a gastrointestinal involvement, which can cause significant weight loss. I have seen a patient who has lost almost 30 kgs of weight over 6 months with this disease. So whenever a patient has unexplained diarrhea, unexplained weight loss, presence to gastroenterologist or internal medicine doctors, amyloidosis should be kept in mind as a possible differential diagnosis. Patient can also have hepatomegaly or liver enlargement, and elevated alkaline phosphatase in the routine blood workup can be a subtle clue to hepatic involvement. The other symptoms include a condition called carpal tunnel syndrome, where patients present with tingling and numbness of hands and fingers. When carpal tunnel syndrome is bilateral, that is, patient has neuropathic symptoms in both hands, this is again something which should raise a high index of suspicion for primary amyloidosis. Of all the symptoms we described, the cardiac symptoms is what is responsible for the patient's morbidity and mortality. As a cardiologist or as an internal medicine doctor, when should we really think of AL amyloidosis? When patients have heart failure with preserved ejection fraction, have thick LV walls, and yet the ECG shows low voltage complexes. Restrictive cardiomyopathy without any obvious cause. There are very characteristic findings like apical sparing pattern, which can be seen on cardiac imaging. Whenever a patient has unexplained proBNP elevation, TROP-T elevation, arrhythmias like atrial fibrillation for which we don't have an alternate cause, or patients have postural hypotension, that is, patient gets up from lying down position or tries to stand up from sitting position, they suddenly feel giddy. These are all soft signs to think of amyloidosis. Heart failure with preserved ejection fraction, low voltage ECG complexes, restrictive cardiomyopathy, postural hypotension. Any patients presenting with these symptoms, amyloidosis should be kept high up on the list of differential diagnosis. And why is it so important to recognize them early? because once patients develop advanced stage cardiac amyloidosis, the median survival drops to less than 6 months without rapid treatment. So this is a main killer of patients with amyloidosis. We are all familiar with seeing routine ECG. As you can see, this ECG, it is very different from what we see in normal patients or normal individuals. These are low voltage ECG complexes where the height of the QRS complex is significantly low. So whenever we see an ECG like this with low voltage complex, amyloidosis should be kept in mind. On the left is the echo of a person with a normal heart. And as you can see, once amyloid deposit in the cardiac muscles, you can see how the thickness increases. I have put in this image. This was one of our patients who presented with cardiac failure. Patient was diagnosed outside as AL amyloidosis and referred to us for treatment. When we did a technetium pyrophosphate scan, and this is not a very expensive investigation, this is a cost-effective treatment which is done in any center which has a nuclear medicine facility. When we saw a technetium pyrophosphate scan, patient had a bright imaging on the technetium pyrophosphate scan. And whenever we see such an image, this is not a primary amyloidosis or a AL amyloidosis. This is the ATTR amyloidosis. So this is one of the very easy tests to perform, which can help us to differentiate between AL and ATTR amyloid. We already discussed about kidney involvement. When patients have frothing in the urine, nephrotic range proteinuria, and ultrasound shows a normal sized or enlarged kidneys, amyloidosis is one of the strong differential. Patient also can have prothrombotic events like renal vein thrombosis or severe edema, which can be often disproportionate to the albumin levels. A renal biopsy can often clinch the diagnosis with a Congo red staining, which can show typical apple green birefringence. So this is the image of a kidney biopsy with the glomerulus, and the arrow points at amyloid deposits, which are seen as amorphous materials on the kidney biopsy. So to summarize, these are symptoms which can mimic many other diseases, and these are symptoms with which the patient presents to many different specialties. But we should not miss the subtle presentations, whether it is neurological in the form of bilateral carpal tunnel syndrome, postural hypotension. Very often, these symptoms are dismissed as diabetic neuropathy in a patient who has diabetes. But carpal tunnel syndrome, especially when it is bilateral or when the neuropathy is painful, symmetric, and unrelenting, we should think of AL amyloidosis. Macroglossia or enlargement of the tongue is a very characteristic feature in amyloid patients, but this is seen in only 20% of the patients. Many of the patients present with chronic unexplained diarrhea, patients would have undergone multiple gastro evaluations, endoscopies, colonoscopy, unexplained weight loss, gastroparesis, dysmotility, bleeding. These are all symptoms which would raise a red flag to make us think about amyloid. Soft signs for the general practitioner, whoever has joined in today. If you see any of these together, please think of amyloidosis. Heart failure with preserved ejection fraction, bilateral carpal tunnel syndrome, periorbital purpura, which is also known as raccoon eyes, painful peripheral neuropathy, adult onset nephrotic syndrome, macroglossia, unexplained weight loss or diarrhea. When should you refer the patients? Any of these symptoms, we should think of amyloidosis, check for serum protein electrophoresis, serum-free light chain assay, and ideally patient should be referred the same week. Suspected cardiac patients should get a troponin and pro-BNP done at baseline. If patients have a nephrotic range proteinuria, they should be referred to a nephrologist who would ideally do a kidney biopsy, which can clinch the diagnosis. What are the basic tests that we can do once we suspect amyloidosis? Serum-free light chain, serum protein electrophoresis, immunofixation, urine immunofixation, along with a simple ECG echocardiogram, which is available everywhere, along with cardiac markers like NT-proBNP and troponin T. It is also important to look at the urine for 24-hour urinary protein and protein creat ratio. These simple tests can help us to clinch the diagnosis. So what are the 3 steps to diagnosis? Number 1 is to see whether there is a monoclonal protein in the blood. And we can achieve this with doing a simple serum-free light chain and a protein electrophoresis with immunofixation. Never forget to check the urine. If a screening for monoclonal protein is negative, It is exceedingly rare that patient has amyloidosis. We have seen patients with a normal blood monoclonal protein workup ending up having AL amyloidosis, and these proteins detected with more sensitive tests like mass spectrometry. But these are a minority of patients. For the vast majority, screening for a monoclonal protein will give us an initial clue regarding this disease. How do we prove the deposition of amyloid? We have to think of organ biopsy, either a kidney biopsy or an endomyocardial biopsy. But very often, if these are not feasible or difficult to do, a simple abdominal fat pad aspirate can help us to identify amyloid deposits with a characteristic apple green birefringence on Congo red stain. Once we prove the diagnosis, it is important to stage the disease. And staging NT-proBNP, troponin T, and differential light chains helps in staging this disease. So the screening triad is serum protein electrophoresis along with immunofixation, urine electrophoresis with immunofixation, and serum-free light chain. If we do these three tests together, and as you can see, within less than 10,000 rupees, we can do these tests at most labs across the country. These are widely available to all the clinicians. And the combined sensitivity for picking up amyloidosis is more than 99%. Tissue biopsy is important. The involved organ biopsy yields the highest. For example, if patient has a proteinuria, kidney biopsy has a 95 to 100% specificity and sensitivity for picking up this disease. Bone marrow biopsy, which we routinely do in amyloid patients, picks up the disease in around 60% of the patients. Abdominal fat pad is very often easy to do in a resource constrained setting, and 70 to 80% pickup rates for amyloidosis. It is important to type the disease because very often what we think as AL amyloidosis may be some other type like ATTR or anti-SAA. So amyloid typing till very recently was not available in India. There were times when we had to send samples to Mayo Clinic for typing in difficult patients, but now that is not the case. There are many laboratories in India who are doing amyloid typing. And if there is an ambiguity in the diagnosis, definitely typing should be done before labeling the patient as AL amyloidosis. This is a characteristic apple green birefringence that is seen with Congo red staining, and this essentially clinches the diagnosis for most patients. Once we diagnose the patients, how do we restratify? Three simple tests, NT-proBNP, troponin T, and differential light chains help us to divide patients into Mayo staging 1 to 4. And why is this important to understand? If we are able to pick up the patients early, the median overall survival is 7 to 8 years. But if we are able to pick up the patient only in advanced stage with cardiac involvement, high troponin T, high NT-proBNP, the overall survival is dismal at less than 6 months. So this is why it is very, very important to identify these symptoms early so that we are able to give the best possible treatment early on in the disease course. As you can see, between stage 1 and stage 4, how the survival reduces. This graph essentially shows us the pink graph at the bottom is stage 4, where the overall survival is very bad, versus the one on top is stage 1, where many of the patients can be potentially cured of the disease. So this is the bedside algorithm that I follow whenever I think of amyloidosis. High index of suspicion for clinical signs. If I'm able to see clinical signs without wasting times, I go for a serum protein electrophoresis, serum-free light chain, along with an immunofixation and urine testing. A fat pad biopsy, or if there is proteinuria, a kidney biopsy along with a Congo red staining would clinch the diagnosis. Clonality assessment would also include a bone marrow testing to see whether there is concomitant increase in plasma cells and associated diseases like multiple myeloma. Staging the disease is essentially with cardiac biomarkers, with the cardiac involvement being the single most important prognostic parameter in this disease. And once we do this, patients should be referred to a hematologist at the early, because earlier we start the treatment, the better it is. Never ever assume that heart failure with preserved ejection fraction, swelling in both legs, or weakness, these are just due to old age. Many of the patients, the diagnosis is delayed because their primary physicians, their family, and everyone tells them these are age-related symptoms. These are never age-related. If we see patients with unexplained swelling in legs, heart failure with preserved ejection fraction, we should always evaluate more. Moving on to the first-line treatment. We are all familiar with the Andromeda trial, where daratumumab was added to the standard bortezomib, cyclophosphamide, dexamethasone backbone for treatment of amyloidosis. And this has significantly improved the outcomes in these group of patients. Unlike many other diseases or many other malignancies, it is important for us to realize that treating amyloidosis is mostly an outpatient treatment. A subcutaneous daratumumab injection, subcutaneous bortezomib injection, oral cyclophosphamide, and oral steroid. These are treatments which can be administered on a weekly basis, on an outpatient basis. Patients tolerate the treatment very well, and these are not toxic treatments which causes hair loss, oral ulcers, and other problems. What do we achieve? What do we aim with treatment? If we go back to the pathogenesis, it is the abnormal plasma cells sitting in the bone marrow which are responsible for this disease. So the first line treatment is to actually kill the plasma cell clone. And the earlier we do it, the more organs are spared. Once the plasma cells reduce, the amyloid protein production stops. And once this happens, we have to wait for the organ recovery. Something which is very important for us to realize as clinicians is once amyloid goes and gets deposited in different organs, there is hardly anything that we can do at present to remove them from the organs. Our control is to shut down the factory making the bad proteins, stop the abnormal plasma cell production. And once this happens, the blood parameter starts to improve, the organ response starts to improve, and very often we are able to get the patients into long-term disease control. Daratumumab, along with BCD regimen, is the standard of care of patients with AL amyloidosis. This is the first-line treatment worldwide, and this should be the standard of care for all our patients. Daratumumab does become an expensive proposition, but we are hopeful that once the patent and other things end, the drug will potentially become cheaper. The standard treatment is weekly daratumumab injections along with bortezomib, cyclophosphamide, and dexa, which is given as oral medications. 6 cycles of treatment, disease reassessment. Along the way, we have to modify the treatment for side effects like neuropathy or fluid retention. Infection remains to be a major problem for our patients. So it is very, very important that we vaccinate the patients against hepatitis B, pneumocystis, and also follow these patients closely for infections. We also give prophylactic medications like Bactrim and acyclovir to prevent viral and PCP infections. Andromeda trial was a landmark trial in this. For hematologists and oncologists who are treating, they are very familiar with the data. But this trial essentially looked at addition of daratumumab to the standard bortezomib cyclophosphamide dexa regimen, significantly better hematological CR rates, 53% versus 18%. And this essentially translates to long-term survival. 10-year follow-up data of the Andromeda trial was recently published in Blood Journal. And as you can see, patients who receive daratumumab upfront, there is a significant progression-free survival benefit as well as overall survival benefit when these patients were followed up for a long period of time. How do we measure response? We looked at normalization of blood parameters or hematological response. A complete response is when the serum and urine immunofixation is negative along with a normal light chain ratio. This is our goal of treating patients. Anything less than that, I would say, is suboptimal. What is important to realize as patients and treating physicians is the hematological parameters usually respond quite fast, but the organ involvement lags behind. So even in patients whose light chain production has become zero, the light chain ratio is normal, cardiac involvement may take 6 to 1 year or even more. The proteinuria can take long time to resolve. So we should not become impatient thinking that the patient is not responding. Hematological response or CR is something which we achieve earlier on, but the organ response usually takes time. And organ response is defined as typically more than 30% drop in NT-proBNP, more than 30% drop in proteinuria, and more than 50% drop in alkaline phosphatase, indicating an improvement in liver disease. What is the role of stem cell transplant in AL amyloidosis? The unfortunate truth is most of the patients, by the time they present to us, have advanced stage cardiac disease and are not candidates for stem cell transplant. But in a cost-effective or cost-constrained society like India, transplant is a one-time treatment which can bring the patients into deep, durable remissions and cure at least a fraction of patients with AL amyloidosis. So autologous transplant is the closest that we come to a cure when we think of amyloidosis. If patients are diagnosed early and there is no cardiac involvement at baseline, such patients should be considered for an autologous stem cell transplant if they are fit. The high-dose melphalan given during the transplant eradicates the plasma cell clone, and we are able to achieve long-lasting hematological responses in more than 50 to 60% of the patients, with many patients surviving for more than 10 years and potentially cured of the disease. And the advantage of transplant is this is a one-time treatment and the effects are long-lasting. Usually, once patients are diagnosed, if there is no cardiac involvement, we screen them to see whether they are fit for a transplant. We give them 3 to 4 cycles of DARA VCD while they are preparing for a transplant and straight away go to a transplant if patient is otherwise fit. Who is an eligible candidate for transplant? Anyone less than 70 with a good performance status, early stage disease without significant cardiac involvement can be considered for transplant. The cost of transplant in most Indian centers is around 5 to 6 lakhs. Now, if you compare it with the cost of daratumumab for 2 years or even 6 cycles of DARA VCD, we can actually see that transplant is probably the most cost-effective option that we can offer our patients. And as you can see, if we are able to transplant patients in early stage compared to giving them chemotherapy alone, transplant offers a significant advantage in terms of overall survival in these patients. The transplant-related mortality or risk of serious complications are extremely low in patients with amyloidosis without cardiac involvement. The transplant-related mortality is around 1 to 2%, and many of the patients can have an overall survival of more than 10 years with a single time treatment if they are diagnosed in early stage disease. The unfortunate truth is many of the patients are not able to get to a transplant, and even if they are treated with the best of treatments, including DARA VCD, the disease does return with time. And what do we do when the disease relapses? Around 50% of the patients treated with DARA VCD will require a second-line treatment within 5 years, and this is a very, very large number. So once patients are in CR, we monitor them every 3 months with a free light chain immunofixation test, as well as the organ-specific markers like proBNP, troponin, and EGFR, which are done every 3 months. Patients should undergo an ECG and echo every year to look for any organ deterioration. A relapse is defined as any increase in the light chain from baseline with DFLC of more than 40 milligram per DL, or if there is a progressive organ involvement. What are the options that we have as of today for relapse? Till a couple of years back, patients with relapsed amyloidosis had a grim prognosis with not many treatment options available in front of us. It included retreatment with older medications which patient was getting like bortezomib and daratumumab, pomalidomide and dexamethasone-based treatment, second transplant. So the overall outcome was very grim. But things have changed in 2026 for patients with relapsed amyloidosis. We have excellent treatments available. Many of them are still in clinical trials, but immunotherapy has essentially changed the treatment landscape of not only multiple myeloma, but also patients with amyloidosis. We have teclistamab, we have belantamab, we have CAR-T, and believe me, all these treatments will be available to us within the next 6 months to 1 year. And this is going to change the landscape of treatment for patients who have progressed on daratumumab. Teclistamab is a BCMA bispecific, which essentially binds BCMA to CD3. We all know about this molecule. This has created wonders in the field of multiple myeloma. In heavily pretreated patients, 60 to 70% respond to it. There is early trial data showing very, very encouraging results for teclistamab in multiple myeloma, as well as AL amyloidosis. So once patients progress on daratumumab, this can be a very useful option for our patients. Teclistamab is available in India, still not licensed for amyloidosis, but it is available to us for use in relapsed myeloma. And we do consider this treatment on a case-to-case basis for patients with amyloidosis. Belantamab mafodotin is an antibody drug conjugate, which again has been used in myeloma with good results, recently launched in India, and it is available for us now for myeloma. and amyloidosis patients who have relapsed on other treatments, this is a potential treatment option. We are all familiar with the CAR-T hype. In lymphoid malignancies, be it lymphoma, B-ALL, or myeloma, CAR-T cell has done wonders. There are various clinical trials which are looking at CAR-T cells in the amyloidosis space also. So with teclistamab, the emerging data is very promising with 90% hematological rates, more than 70% of the patients achieving a CR. And what is phenomenal to note is that the time to achievement of response is rapid. It is not months or years. Patients usually respond within day to weeks. And the toxicity profile is usually well managed. We are all familiar with their use in multiple myeloma patients. Infection remains to be a serious concern, but I think we are getting better at using these molecules. There are multiple trials going on across the world for using CAR T cell therapy in patients with AL amyloidosis. We still do not have an approved treatment, but I can see that the early stage results are extremely encouraging with almost 100% of the patients having favorable responses. So we are hopeful that within the next few years, we will have a CAR-T product for our amyloidosis patients who have relapsed on daratumumab-based treatment. The talk would be incomplete without discussing about antifibril therapy. What exactly is antifibril therapy? So when we think of treating amyloidosis, we can look at it from two aspects. The first aspect is to kill the plasma cell clone, shut down the factory which is making the bad proteins. That is what we have been doing all these years. But what about the amyloid proteins which have already gotten deposited in the heart or the kidneys? Till very recently, we did not have any ways or means to remove this. But antifibril therapy looks at dissolving or removing the amyloid deposits which have already been deposited in the organs. This can prove as a valuable adjunct to treatments like DARA-VCD. Whole lot of medicines in early clinical trials, but among the molecules, CAEL-101 has shown a lot of promise. Already phase 3 trials are going on for CL-101 and birtamimab. These are two molecules where phase 3 trials of antifibril therapy is ongoing, and we are hopeful that in the coming years, the treatment of amyloidosis would switch from a plasma cell directed strategy to a combined treatment where plasma cell directed treatments like daratumumab BCT will be combined with a antifibril treatment for better responses. So to put it all together and summarize my talk, whenever we have a newly diagnosed amyloidosis patients, it is important to look at the cardiac involvement, stage them according to the Mayo classification. The standard first-line treatment is DARA-VCD for a minimum of 6 cycles, followed by response assessment. All patients who are fit and do not have a significant cardiac involvement should be considered for autologous stem cell transplant in the Indian setting because this remains to be the most cost-effective treatment that we can offer for our patients upfront. If patients have advanced stage cardiac disease, the outcomes are dismal and patients usually succumb to either arrhythmias or cardiac failure. So such patients should be treated with daratumumab-based treatment in close conjunction with a cardiologist. Almost 50% of the patients do relapse despite DARA-based treatments, and we have encouraging data coming up from clinical trials for newer molecules like teclistamab, belantamab, and CAR T-cell therapy, which have shown a lot of promise in the myeloma space, but which is yet to come into the amyloidosis space. So take-home message for each and everyone who has joined. It is very nice to discuss about fancy treatments, CAR-T, bispecific, so on and so forth. But the crux of today's talk is not how to treat amyloidosis. It is how to diagnose, when to suspect it, when to test for it. If we are able to pick up the disease early, we will be able to cure most of the patients. So the unmet need in amyloidosis is not treatment or relapse disease. The unmet need is early diagnosis. Very, very, very important to suspect the disease. Any patient with unexplained fatigue, weight loss, GI symptoms, breathing difficulty, proteinuria, cardiac failure, neuropathic symptoms, the list goes on. Patients may present to any of these specialists, and this is a diagnosis that unless we keep it with a high index of suspicion, we are going to miss diagnosing amyloidosis. And once the disease progresses with a worsening cardiac involvement, no matter what we do, we are unfortunately not able to salvage most of the patients. Suspect the diagnosis, very easy tests available, serum-free light chain, urine and serum immunofixation, available under 10,000 rupees in most labs. This will help us to diagnose 99% of the patients. Important to type the disease as AL versus ATTR amyloidosis, the treatment can be vastly different. Once we diagnose this, treat the disease aggressively, transplant patients who are eligible. Relapse is still a sad reality, but we are getting better at treating relapses with immunotherapy and newer treatments coming into the picture. Going back to our patient, we started the patient on daratumumab BCD treatment. Within 6 months, patient had a significant improvement in his cardiac function as well as renal parameters. Patient got back to his work, and eventually his disease went into a CR with improvement in organ function within 6 to 9 months. Patient was able to go back to his work. He was able to get on with his life. Now he's active, back to work, traveling, and currently busy with his daughter's wedding. So, to summarize my talk with a single quote, for all the amyloidosis patients, the treating doctors, and physicians across specialties who have joined in today, amyloidosis is not a death sentence. It is a misdiagnosis. The onus on diagnosing the disease early lies with each and every one of us. Any unexplained symptom, high index of suspicion, if we suspect early, test early, and treat early, most patients live on for many years, and we are able to potentially cure some patients. This is where I work. Rajagiri Hospital in Cochin. We have a dedicated center for hematological malignancies, stem cell transplant, and CAR T cell therapies. And we have an integrated team which includes a cardiologist, nephrologist, neurologist, ID physician, and hematologist taking care of our amyloid patients. I thank you all for patient listening, and I'm happy to take questions.
Thank you so much, sir. It was a very wonderful and very much enlightened session. We have few questions, so we will take those questions first, and then we can discuss on further things if you want.
Yeah,
So,
please go ahead.
the question is from Vikas Bhatia. What conditions are most commonly misdiagnosed as amyloidosis?
So, cardiac failure, top of the list. Heart failure with preserved ejection fraction. Patients sometimes are treated for years for cardiac failure. Proteinuria, frothing in the urine, presence of protein in urine. This is often misdiagnosed as only renal problem. Neuropathic symptoms. Patient can have tingling and numbness in the hands, feet, burning sensation. There is a condition called carpal tunnel syndrome where patients sometimes develop weakness of the hands, tingling numbness of the fingers. Carpal tunnel syndrome on both hands or bilateral carpal tunnel syndrome, patient should be evaluated for amyloidosis. Patients present to gastroenterologists with symptoms like unexplained diarrhea, loss of appetite, weight loss. I have seen patients having weight loss of 20-30 kgs over 6 months who have undergone endoscopy, colonoscopy, PET scans, but never thought of amyloid. So the thing that we need to understand is amyloidosis can literally present with any of these symptoms. And unless we keep a high index of suspicion, this diagnosis can be very, very easily missed. The photos I showed you, the raccoon eyes, the bleeding around the eye, the tongue swelling, these are very rare. You will see it in 10 to 20% of the patients, not more than that. But it is the subtle symptoms like fatigue, unexplained swelling in the legs, proteinuria, problems in the heart, neuropathic symptoms. These are all usually initial presentations of amyloidosis. So literally, it can present to any specialty. And which is precisely why the diagnosis is delayed. Because by the time patients reach a hematologist, they would have usually seen 3 to 4 other doctors and spent 1 to 2 years. And this is not only for India. The data that I presented earlier, that is from UK. So it is across the world. The problem is patients are misdiagnosed or are diagnosed late.
The next question is from an Indian perspective, how many people are diagnosed with amyloidosis every year? So it's an estimate.
So the prevalence is around 1 in a million. But those numbers don't actually speak the reality. Because let's say if there are 10 patients with amyloidosis walking around in the society, you are able to pick up only one of them. So the actual numbers may be 10 times higher than what we see or what is projected. And which is why I was saying in the beginning that this is actually not a rare disease. This is a common disease which is rarely diagnosed. So there is a difference there.
The next question is which doctor is typically the first to see and identify amyloidosis?
So any doctor who is trained in suspecting this would definitely diagnose it without delay. So I'll give you an example. Any patient comes to neurologist at Rajagiri Hospital with carpal tunnel syndrome. Patients are referred to us. Whether or not they have amyloid is a different question, but they are referred to a hematologist for evaluation. Heart failure with preserved ejection fraction, which basically means heart failure with the ejection fraction remaining normal. They are definitely referred to us. It's a different thing that 50% of them may not have amyloidosis also. But the point is, suspicion across specialties is very important. Any unexplained neuropathy, patient should be worked up for a monoclonal protein. And it is not very difficult to do. These are all things which we can pick up from routine blood tests which are available across the country.
So we have another question by Dr. Sumalata. How to diagnose amyloidosis on immunofixation?
So see, the diagnosis of amyloidosis is not only made on immunofixation. Immunofixation will only tell us whether there is a monoclonal protein. Monoclonal protein can be present in multiple myeloma. It can be present in monoclonal gammopathy of undetermined significance. It can be present in smoldering myeloma and a whole lot of other conditions. Immunofixation, what it tells us is whether there is a monoclonal protein, and typically a lambda light chain is more commonly seen in amyloidosis. So whenever we have a suspicion, for example, a patient is presenting with proteinuria, we always think of amyloidosis if the kidney size is normal or enlarged. So we do an immunofixation not to diagnose amyloidosis, but to understand whether there is a monoclonal protein in the blood. And once we establish the presence of this monoclonal protein, we very often do a bone marrow to see whether the plasma cells are increased. The diagnostic test for an amyloidosis is to demonstrate the amyloid tissue on an organ involved or fat pad biopsy or a rectal biopsy by Congo red stain with a typical apple green differentials. What immunofixation can tell us is, number one, is there a monoclonal protein? Number two, what is the light chain restriction? More often than not, we see a lambda restriction. That does not mean if the patient has a kappa predominance, you cannot have an amyloid, but lambda light chain restriction is more common. And number three, is there a concomitant myeloma? Now, what we did not discuss is very often amyloidosis can coexist with multiple myeloma, which is why patient may have a lytic lesion in the bone, increased plasma cell, along with an amyloid deposit in his heart. 30% of the patients can have a coexisting myeloma. So even to pick that up, an immunofixation is important. So identifying a monoclonal protein, number one, looking at the organ damage and biopsy from the organ. If the organ biopsy is not possible, at least an abdominal fat pad or rectal biopsy to demonstrate amyloid deposits. This will clinch the diagnosis. Immunofixation is a valuable clue to suspect the disease.
Wonderful, sir. So I have a couple of questions, sir, for you.
Yeah, you please go
So,
ahead.
so from a patient care perspective, what lifestyle or supportive care measures can like improve the quality of life when during the treatment time?
So wonderful question. The first message that we should give patients is amyloidosis and the treatment, including daratumumab, bortezomib, cyclophosphamide, comes with a significant infection risk. So before we venture into treatment, all patients should receive vaccination. Annual flu vaccine, pneumococcal vaccine with Prevnar 20, which is a lifetime, once in a lifetime vaccine, Shingrix vaccination, hepatitis B vaccination. To reduce the infection risk, patients should be vaccinated. Number one. Number two, patients should avoid crowded areas, relatives who are sick. And I wouldn't say they should isolate and lock themselves up in a room, but they should avoid situations where they can get an infection. Whatever precautions we used to follow during COVID, hand washing, wearing a mask, these are the bare minimum that we can definitely do. Number three, in spite of all this, patients can develop infection. And if patients on treatment get fever, get any signs of infection, they should meet their treating doctor immediately, because these infections can sometimes spiral up very, very fast. Is there any particular food which helps? The answer is no. Patients should have a healthy, balanced, and high protein diet. There is no dietary restriction. High fiber diet has been shown to be helpful, not only in amyloidosis, but even in diseases like multiple myeloma. Unhealthy diet, if patients are having, cut salads, juice from outside, we discourage, not because salad causes a problem, but because patient can develop an infection. Once patients develop a cardiac failure, that can adversely affect their energy levels, lifestyle, and such patients should be treated in close collaboration with a cardiologist. Decongestive measures like diuretics, medications to reduce fatigue, transfusions to maintain hemoglobin. So that is a separate entity in itself. But amyloidosis patients per se, vaccination, good healthy diet, high protein diet, diet which is high in fiber, not particular dietary restriction, be active and stay away from infections and keep a very high suspicion for infections.
Sir, another question, sir. As I am a genetic counselor, so my most questions are for the caregivers and the family. So, what
Absolutely.
message would you like to give what message would you like to give to caregivers or families supporting patient with amyloidosis?
So we have an amyloidosis support group in India. Mr. Satish Chandra has done a fantastic, phenomenal job. 5 years back, there was no support group for patients. So if you are a newly diagnosed amyloidosis patient, I would encourage each and every patient to join the amyloidosis support group of India. ASGI is a registered group, has a national presence, has connect with one of the best clinicians in India who diagnose and treat amyloidosis. So each and every person, regardless of which state they are in, should definitely be a part of ASGI. It not only helps them to connect with best amyloidosis specialists in India and even across the world, it also helps them to connect with other patients, learn from each other, and be a strong force. My message for amyloidosis patients is do not become worried or scared about this disease. There are excellent treatments available today, and we are able to salvage majority of the patients with amyloidosis. Do not be scared of stem cell transplant. Stem cell transplant is not a surgery. Many people think like heart or kidney transplant, bone marrow transplant is a surgical procedure. Bone marrow transplant is a procedure where patients' healthy stem cells are collected from the blood. An injection like melphalan is given as an infusion, just like how you give a normal drip, to destroy any other remaining abnormal cells in the marrow. And stem cells are given back to the patient like a blood transfusion. If you are an amyloid patient, please ask your treating doctor whether you are eligible for a transplant. If you don't have a cardiac problem, if you're an amyloid patient, you are less than 70 years of age, chances are you will be eligible for a autologous transplant. And despite all the fancy treatments that we discussed today, including CAR-T and cellular therapy and belantamab, transplant still remains to be the most cost-effective and one of the best treatments that we can offer our amyloid patients, provided they are fit for treatment and the cardiac involvement is not too much. The third is, even if the disease relapses, few years back, we hardly had any options. We had pomalidomide, we had melphalan, we had other medications. But now we are at a situation where we have excellent medications like teclistamab. We'll soon have CAR T cell therapy. We already have belantamab hitting the Indian markets. So there are a lot of options even for relapse patients. Right from diagnosis to treatment to transplant to relapse. If we are able to pick the patients early, treat them effectively, we will be able to control the disease in all and cure at least some of them. So, as a patient, we are all there for them. There is an entire society in the country who's looking at amyloidosis patients. Please be a part of that and connect with your physician and ask them the right question. And if there is any person, your relative, your family member, your friend, who has symptoms of amyloidosis, please tell them to consult a hematologist. We are all aware, at least patients are very well aware of the amyloidosis symptoms. There might be more people in your family, there might be your distant relatives, someone at your office who's struggling with these symptoms. Awareness regarding the symptoms and timely testing can help to detect this disease early. And if we detect the disease before the amyloidosis affects the heart, believe me, we are able to cure a large fraction of patients.
Thank you so much, sir. So I guess we don't have any other questions. So we are at the end of the session now. So as we come to the end of the session today, I would like to sincerely thank Dr. Nikhil sir for such a insightful and informative discussion. Your expertise, clarity, and valuable perspective has truly helped us better understand this rare and complex condition, especially the importance of early diagnosis, multiple disciplinary care, and the evolving treatment approaches. I would also like to thank everyone who joined us today for your active participation and interest in the ORD Info Series. On behalf of ORDI and the organizing team, thank you once again, Dr. Nikhil sir, for your time and contribution. Wishing everyone a wonderful evening ahead. Thank you so much. Thank you.
Thank you.